Okay, we're going to be talking about intracranial hypertension, brain monitoring, and traumatic brain injury today. The objectives of this talk are to review the important physiological concepts in intracranial physiology in relation to the blood flow, regulation of pressures, and monitoring. We will also review the pathophysiology of traumatic brain injury and review the basic principles in management of traumatic brain injury. From the historical perspective, Alexander Monro was a physician-scientist from 1733 to 1810 who first said that the brain is enclosed in a non-expandable bone. The brain itself is essentially incompressible, and there is a balanced inflow and outflow of blood to keep the volume constant. George Kelly was one of his students who said that the blood volume in the brain remains constant. François Magendie said that the cerebral ventricles are filled with fluid, and Cushing was the first one to describe the clinical consequences of raised intracranial pressure. All of these findings came to be known as the modified Monro-Kelly doctrine, which essentially says that with an intact skull, the sum of the volume of the brain with the CSF and intracranial blood flow is constant. Increase in one should cause a reduction in one or both of the remaining two. This forms the physiological principles of traumatic brain injury and intracranial hypertension. Let's talk about the pathophysiology of the intracranial vault in respect to the CSF. The choroid plexus makes approximately 70% of the CSF in the brain. The volume of the CSF in a 4 to 13-year-old child is approximately 90 ml. The rate of formation is approximately 500 cc's a day. The drainage of the CSF occurs via the arachnoid villi and granulations, which then goes into the superior sagittal sinus and then into the spinal root sleeve venous drainage. Some drainage of the CSF also occurs via the olfactory bulb and mucosa into the deep cervical lymphatics. Let's move along to the pathophysiology of the intracranial vault and talk about the cerebral blood flow. The primary goal of the therapy is to ensure adequate cerebral oxygen delivery. The cerebral oxygen delivery depends upon the cerebral blood flow and the arterial oxygen content. The determinants of cerebral blood flow include the cerebral perfusion pressure, the cerebral metabolic rate for oxygen, or the CMRO2, the partial pressure of carbon dioxide, or the PaCO2, and the partial pressure of arterial oxygen, or the PaO2. An important concept to understand in the brain vasculature is the concept of cerebral autoregulation. The cerebral autoregulation is a unique property of the brain vasculature, which essentially means that the brain can maintain a constant perfusion despite fluctuating blood pressures. And under normal conditions, there is a constant cerebral blood flow over a cerebral perfusion pressure ranging from 50 to 150. This graph further explains the concept of cerebral autoregulation. Look at the x-axis, which has the cerebral perfusion pressure in millimeters of mercury, and look at the y-axis that has the cerebral blood flow in ml per 100 grams per minute. I want you guys to focus on the curve that says normal, or the graph that says normal, and then we'll go to the graph that says ischemia and chronic hypertension. When you look at the normal graph, you'll see that over a cerebral perfusion pressure between 50 and 150, the cerebral blood flow stays constant. If you look at the top in the vascular caliber cartoon or graph, you will see that the caliber of the blood vessels changes as the cerebral perfusion pressure increases. Initially, there is a vasodilatory cascade zone, and then there is a zone of normal autoregulation, and then beyond 150 millimeters of mercury, there is an autoregulation breakthrough zone. In cases of chronic intracranial hypertension, this curve or this graph shifts towards your right. In ischemia, this autoregulation is completely lost, and there's a linear relationship between the cerebral perfusion pressure and the cerebral blood flow. This is called the loss of autoregulation. Let's talk about the cerebral metabolic rate for oxygen, or the CMRO2. An increase in the CMRO2 is normally accompanied by an increase in the cerebral blood flow. Fever and seizures cause an increase in the cerebral metabolic rate for oxygen and therefore increase the cerebral blood flow. It is very important, therefore, to treat them in any case of traumatic brain injury. So don't let a kid seize and don't let them have fever. In traumatic brain injury also there's an uncoupling of metabolism and flow. In a study by Jaggi and al., they found that the cerebral metabolic rate for oxygen significantly was depressed in patients who subsequently died or remained in a vegetative state, whereas higher values were obtained in patients who later regained consciousness. Let's move along and talk about carbon dioxide and the regulation of cerebral blood flow. Carbon dioxide crosses the blood-brain barrier, induces changes in the perivascular pH, and then alters the vasomotor tone. As the PaCO2 increases, the cerebral blood flow increases, whereas low PaCO2 levels cause vasoconstriction. This graph over here further clarifies what we just talked about, the PaCO2 in the cerebral blood flow. As the PaCO2 is increasing, the cerebral blood flow is increasing. As the PaCO2 decreases, the cerebral blood flow decreases. Let's talk about the effect of PaO2 on the regulation of cerebral blood flow. Hypoxia causes cerebral vasodilation and increases cerebral blood flow. As PaO2 falls below 50 millimeters of mercury, the cerebral blood flow begins to rise dramatically. This is represented in this graph. Your x-axis has the gas tension and the y-axis has the blood flow. As the PaO2 decreases, the cerebral blood flow starts increasing. This graph summarizes what we just talked about regarding the effects of the PaO2, the PaCO2, and the cerebral perfusion pressure. As you see, the PaCO2 increases, the cerebral blood flow increases. As the PaO2 decreases, the cerebral blood flow increases. This is the autoregulation curve that we talked about over here. Let's talk about the analysis of intracranial pressure. In the horizontal position, in normal healthy adults, the ICP value ranges between 7 and 15 millimeters of mercury. In the upright position, the mean intracranial pressure is approximately minus 10 millimeters of mercury and does not exceed minus 15 millimeters of mercury. In infants and children, normal intracranial pressure is approximately 5 to 10 millimeters of mercury. Moving along to traumatic brain injury and the pathophysiology and basic principles of management. So the epidemiology of traumatic brain injury, the incidence is approximately 23 cases per 100,000. Approximately 100,000 to 200,000 new cases of pediatric traumatic brain injury are reported every year, and there are approximately 3,000 to 4,000 pediatric deaths annually. And approximately 10 to 15% of traumatic brain injury cases in infants and children are severe, and these contribute to most of the observed death or permanent brain damage resulting from the traumatic brain injury. So this figure over here is a schematic representation of the three cascades leading to cerebral edema. On the top left, you see there is cellular swelling, which is predominantly seen in the astrocyte and is stimulated by potassium, acidosis, and glutamate and arachidonic acid, and other factors along with. This key pathway is less representative of a toxic process and more consistent with a homeostatic or mediator-driven process. Neuronal swelling from pump leak probably is less important. At the bottom over here, you see osmolar swelling from contusion necrosis. In the hours after injury, reconstitution of the blood-brain barrier or development of an osmolar barrier around a contusion sets the stage for massive local swelling as the macromolecules in the contusion break down, increasing local osmolality. On top right over here, you see the vasogenic edema, which results from protein and water accumulation across the damaged blood-brain barrier, which is formed by tight junctions, the astrocyte foot processes. Direct vascular disruption by trauma, reactive oxygen species such as hydroxyl radical, superoxide anion, and peroxynitrate radicals, and metalloproteases, kinins, and leukotrienes contribute to damage of the blood-brain barrier. This picture over here further categorizes the mechanisms proposed to be involved in the evolution of secondary damage after severe traumatic brain injury. Three major categories for these secondary mechanisms are ischemia, excitotoxicity, energy failure, and cell death cascades, cerebral swelling, and axonal injury. So as you see over here, because of the injury there is ischemia, release of potassium, glutamate, superoxide ion, amino acids, cytokines, and calcium, leading to neurotoxicity, further leading to necrosis and apoptosis of the cells, and also causing astrocyte swelling, all leading to an increase in the intracranial pressure. There is direct parenchymal and vascular disruption and depolarization, leading to a disruption of the blood-brain barrier, causing vasogenic edema and causing increase in the intracranial pressure. Because of a contusion, there is an increase in the tissue osmolar load, leading to an increase in the intracranial pressure. Contusion itself leads to the hematoma, and hematoma causes an increase in the cerebral blood pressure. Also, there is a vascular dysregulation, leading to an increase in the cerebral blood volume and an increase in the intracranial pressure. Let's talk about the clinical management of traumatic brain injury. This is the Glasgow Coma scale, which is different for adults and for children. For an infant less than 1 year old, the categories of response are different, because children less than 1 year old, two different things. For children 1 to 4 years of age, it's a little different again, and from age 4 to adulthood, it's the same. When you get a child with traumatic brain injury, it's most important to make sure that your airway is patent, and we talk about the ABCs. So the criteria for the intubation of the head-injured child: if you have a Glasgow Coma score of less than 8, you have a decrease in the Glasgow Coma score of more than 3, you have unequal pupils or anisocoria, if there's apnea or hypercarbia, loss of pharyngeal reflexes, or there's spontaneous hyperventilation causing a PCO2 less than 25. Drugs for intubation of a head-injured child. If you have a child who is in cardiopulmonary arrest, you use the resuscitation drugs. This is also variable based off what institution you practice in. If you have a hemodynamically unstable child, you can use etomidate, lidocaine, and rock or vec. Alternatively, you can use fentanyl, lidocaine, and rock or vec. If you notice over here, the dose of fentanyl is approximately 2 to 4 mics per kilo. The usual dose of fentanyl for rapid sequence intubation is approximately 1 mic per kilo. We use higher doses of fentanyl in children with traumatic brain injury to prevent intracranial pressure spikes. If the child is hemodynamically stable, again you have the option of rock or vec, etomidate, or fentanyl, and midaz, along with rocuronium or vecuronium. The main problem with etomidate is related to adrenal suppression, and a lot of centers are moving away from using etomidate for rapid sequence intubation in children. Let's talk a little bit about brain herniation. Mass lesions occur in approximately 30% of the children with traumatic brain injury, and patients with rapidly expanding epidural hematomas can present with pupillary dilatation, systemic hypertension, bradycardia, and extensor posturing, which is known as the Cushing's triad. When you get a child with traumatic brain injury and the child has an expanding mass lesion leading to any of the herniation syndromes, the signs and symptoms of which include pupillary dilatation, systemic hypertension, bradycardia, and extensor posturing, you emergently treat it. The treatment is essentially giving 100% oxygen, hyperventilating the child, and giving mannitol or 3% saline or hypertonic saline, and getting an emergent CT scan or taking them to the OR for a decompressive craniectomy. Diagnostic studies and monitoring modalities. There is a Marshall classification, which is most commonly used classification of CT scan findings in traumatic brain injury. An important point to remember is that routine reimaging is not recommended unless there is a change in the intracranial pressure or there is a change in the neurological exam. It's also important to remember that 15% of adults in a study with traumatic brain injury and a normal CT scan had developed significant intracranial hypertension. The take-home point being that a normal CT scan does not rule out increased intracranial pressure. This is the Marshall classification of cranial CT scans, and it's classified into 4 categories. There's diffuse injury, there's diffuse injury 2, there's diffuse injury 3, and diffuse injury 4. Let's look at pictures of subdural hematomas and epidural hematomas. On your left, you see a CT scan image of a subdural hematoma, and over here is a pathological specimen of someone who had a subdural hematoma. The subdural hematoma essentially takes the shape of the dura. Okay. You also see a midline shift over here, and this is what a subdural hematoma looks like on a pathological specimen. This is what an epidural hematoma looks like on a CT scan. It's a crescent-shaped mass, and this is what it looks like on a child who probably died. Okay. There are some advanced monitoring techniques like stable xenon enhanced CT scan. There are radioactive inhaled or injected xenon methods, and there's transcranial Doppler methods, which are beyond the scope of this topic. So when do you measure intracranial pressure? The current pediatric guidelines recommend ICP monitoring for children with severe traumatic brain injury with a Glasgow Coma scale of less than 8. The presence of an open fontanelle does not preclude the development of intracranial hypertension or negate the utility of ICP monitoring. The ICP monitors can be placed in the lateral ventricles, the parenchyma, the subarachnoid space, the subdural space, or the epidural space. Intraventricular catheters coupled to an external strain gauge are the gold standard for measurement of intracranial pressure. The complications of ICP monitoring are infection, hemorrhage, and CSF overdrainage. Overdrainage of the catheters can also result in rapid emptying of the ventricular system and development of subdural hematomas due to coagulation and obstruction of the subdural vessels. After 5 days of monitoring, the risk of infection starts to increase with an overall estimated risk of 5%. It is also important to note that in a fluid-filled container, the pressure is the same wherever one chooses to measure it within that space. Again, coming back to the Monroe-Kelly doctrine. What this essentially means is that if you put the monitoring catheter and the tip of it, if it's in the parenchyma versus it's in the CSF, the pressure will be the same. Monitoring cerebral metabolism. You can do a jugular venous saturation, which has been done extensively in adults, and desaturations below 50% are associated with mortality in adults. Near-infrared spectroscopy or a NIRS monitor has been used to track the oxidative state of cytochromes in the brain. NIRS has also been used for assessment of cerebral metabolic status in hypoxic ischemic neonates and is gaining a lot of favor in postoperative heart surgeries. Treatment of traumatic brain injury in the ICU and intracranial pressure and CPP thresholds. Based on various studies, we know that adult victims of severe traumatic brain injury with intracranial pressure greater than 20 millimeters have a poorer outcome than those without increased intracranial pressure. 4 of the 5 major studies, including a study of more than 230 cases of severe traumatic brain injury, reported a poorer outcome with an ICP more than 20. As with ICP, there has not been a randomized controlled trial that has defined the optimal cerebral perfusion pressure for traumatic brain injury. In severe traumatic brain injury, 4 studies defined the cerebral perfusion pressure associated with poor outcome as being between 40 and 65. As a general rule, you want to keep the cerebral perfusion pressure above 50 in infants and above 60 in toddlers and adolescents. So to summarize this slide, essentially what we say is that keep the ICP less than 20 and keep the cerebral perfusion pressure above 50 in infants and keep it above 60 in toddlers and adolescents. Remember that your cerebral perfusion pressure is your mean arterial pressure minus your intracranial pressure. So if you have to artificially drive up the mean arterial pressure with inotropes or vasopressor agents, you have to do that to keep the CPP up. The first goal is to keep the ICP less than 20. Moving along to another strategy for the treatment of traumatic brain injury, which is ventricular CSF drainage. So Fortune et al. Compared the effect of CSF drainage and mannitol in adults after traumatic brain injury and observed similar effects on cerebral blood flow and ICP. CSF drainage was associated with a greater increase in jugular venous saturation than mannitol administration, and intermittent versus continuous drainage strategies have never been compared. Let's talk about osmolar therapy with mannitol. Blood-brain barrier permeability and increases in cerebral blood volume play only limited roles in the development of cerebral swelling, and tissue osmolar load may be more important. Mannitol reduces intracranial pressure by two mechanisms. It decreases blood viscosity with a resultant decrease in blood vessel diameter and cerebral blood volume. This is dependent upon intact viscosity autoregulation that is linked to the blood pressure autoregulation. Mannitol also reduces ICP via an osmotic effect. Results from the movement of water from parenchyma into the circulation. The effect is dependent upon an intact blood-brain barrier, and changes in serum osmolarity reduce brain water only in the relatively normal brain regions. It may also accumulate in the injured regions, and a severe osmotic shift may occur, possibly exacerbating swelling. Mannitol is excreted unchanged in the urine, and the risk of development of acute tubular necrosis and acute renal failure has been suggested with serum osmolarities greater than 320 milliosmoles. Hypertonic saline has been gaining popularity as an osmolar therapy. Hypertonic saline for treatment of intracranial hypertension was first described as early as 1919. The penetration of sodium across the blood-brain barrier is low. It shares with mannitol both the effects on the cerebral blood volume and on the osmolar gradient. It also helps in restoration of cell resting membrane potential, stimulation of the atrial natriuretic peptide release, and inhibition of inflammation and enhancement of cardiac performance. Make sure that we keep the serum osmolarity less than 360 milliosmoles per liter. Sedation, analgesia, and neuromuscular blockade in traumatic brain injury. They should be used once appropriate monitoring is established and is integrated into the first-year treatment. You use narcotics such as fentanyl. You use benzodiazepines, and then the third-line agents as barbiturates. Make sure that we use intermittent doses of lidocaine and or thiopentol to blunt the excessive rises in intracranial pressure secondary to routine patient maneuvers such as suctioning and care. Regarding the head position in traumatic brain injury, both ICP and mean carotid pressure were noted to be reduced in the 30-degree position versus the 0-degree position. Head elevation and midline position improved jugular venous and possibly CSF drainage. Anti-seizure prophylaxis. Prophylactic use of anti-seizure therapy is not recommended at traumatic brain injury. Phenytoin has been shown to reduce the incidence of early patients in a single study of children with traumatic brain injury. Infants and toddlers are at a more severe risk for seizures. after traumatic brain injury. So this algorithm over here explains what to do as a first-tier therapy for traumatic brain injury with a GCS less than 8. So you insert an intracranial monitor, maintain the age-appropriate CPP, which is between 50 and 60. If you still cannot get the ICP under control, provide sedation and analgesia and elevate the head end of the bed by 30 degrees. Consider CSF ventriculostomy. Consider neuromuscular blockade. Consider mannitol. Consider hypertonic saline therapy. And consider mild hyperventilation. And if all of these still do not help, move on to the second-tier therapy. So moving on to the second-tier therapies, refractory intracranial hypertension is seen in approximately 20 to 40% cases of severe traumatic brain injury. The mortality rate is much higher and is 30 to 100% in cases of refractory intracranial hypertension. The second-tier therapies include barbiturates, hyperventilation, hypothermia, decompressive craniectomy, and lumbar CSF drainage. So again, the second-tier therapies, despite the first-tier therapies, your ICP is not under control. You may consider barbiturate therapy. You may consider hypothermia. You may consider hyperventilation. You may consider lumbar drainage. You may consider decompressive craniectomy. Let's talk a little bit about the role of barbiturates in intracranial hypertension. They can decrease the cerebral metabolic rate for oxygen by 50%. Goodman et al. Demonstrated an improvement in the brain interstitial concentration of lactate and glutamate, accompanied by a reduction of the intracranial pressure. The endpoint of barbiturate therapy is burst suppression, which we'll look at in a subsequent slide. Suppression periods are characterized by activity less than 10 millivolts, and 4 to 5 second periods of suppression are followed by bursts. Pentobarbital or thiopentol can be used. So this is what a burst suppression pattern looks like. So this is a flat EEG, and then you have the burst, and then you have a suppression again. Hyperventilation. Prophylactic hyperventilation depletes brain interstitial bicarb buffering capacity and is accompanied by gradual loss of local vasoconstrictor effects. The goal is to make sure that your PCO2 stays between 35 and 40 millimeters of mercury. Hyperventilation is appropriate if you think that the kid is herniating. In the absence of signs and symptoms of herniation, there is no physiological rationale for applying prophylactic hyperventilation. Hypothermia. Hypothermia is useful for the management of increased intracranial pressure in adults with traumatic brain injury. You want to keep the temperature between 32 and 34 degrees in children as well. Hyperthermia, we definitely know, is extremely deleterious in experimental models of traumatic brain injury, and it exacerbates neuronal death. Decompressive craniectomy is a second-tier therapy and should be used depending upon the expertise and discretion of the team. Lumbar CSF drainage. It is an effective modality, but to avoid the risk of herniation, the patient must have open basilar cisterns and no important mass effect or shift, and a functional ventriculostomy must already be in place from above. So important things to remember: aggressively manage hypotension, aggressively manage hypoxia, treat fever, and do not let the child seize. That's the end of the lecture.